Welcome to NurseEdScholar. I'm so glad you're here for some helpful nursing content. I've chosen to use AI faceless videos like this one because I'm not very comfortable being on camera, but I still want to bring valuable information directly to you. These videos are designed to be short and focused, perfect for busy nursing students who are juggling school, work, and life. Each one is packed with the key nuggets you need to succeed in nursing school and beyond. So please take a moment to check them out and be sure to watch all the way to the end. Thank you for being here and welcome again to NurseEdScholar. Acid-base balance imbalances and the components of an ABG. Part 1. Acid-base imbalances develop when a person's normal homeostatic mechanisms are dysfunctional or overwhelmed. One type of acid-base imbalance is acidosis, wherein the blood is too acidic or has a low pH, such as vinegar. It develops when there is an excess accumulation of acid. The body produces two types of acid, therefore there are two types of acidosis: respiratory acidosis and metabolic acidosis. On the contrary, alkalosis is a condition wherein the blood is relatively too basic or has a high pH, such as baking soda. Alkalosis develops when there is an excess accumulation of bicarbonate and loss of acid. There are also two types of alkalosis: respiratory alkalosis and metabolic alkalosis. When acid-base imbalances occur, the body activates its compensatory mechanisms, the lungs and the kidneys, to help normalize the blood pH. The kidneys compensate for respiratory acid-base imbalances, while the respiratory system compensates for metabolic acid-base imbalances. This does not correct the root cause of the problem. If the underlying condition is not corrected, these systems will fail. Now let's discuss the 6 components of an arterial blood gas. Please memorize these numbers to solve ABG problems. First, we will start with the pH, which is the concentration of hydrogen ions and determines the acidity or alkalinity of body fluids. A pH less than 7.35 indicates acidosis, and a pH greater than 7.45 indicates alkalosis. The normal ABG level for pH is 7.35 to 7.45. The body is best between these numbers. The body's tolerance for alterations is very narrow. A pH below 7 or greater than 7.6 for even a short period of time can result in death. PaCO2, or partial pressure of carbon dioxide, shows the adequacy of the gas exchange between the alveoli and the external environment, which is called alveolar ventilation. Carbon dioxide cannot escape when there is damage to the alveoli. Excess carbon dioxide combines with water to form carbonic acid, causing an acidotic state. When there is hypoventilation at the alveolar level, for example in COPD, chronic obstructive pulmonary disease, the PaCO2 is elevated, and respiratory acidosis results. On the other hand, when there is alveolar hyperventilation, as seen in hyperventilation, the PaCO2 is decreased, causing respiratory alkalosis. For PaCO2, the normal range is 35 to 45 mmHg. PO2, or partial pressure of oxygen, indicates the amount of oxygen available to bind with hemoglobin. The pH plays a role in the combining power of oxygen with hemoglobin. A low pH means there is less oxygen in the hemoglobin. For PaO2, the normal range is 80 to 100 mmHg. SO2, or oxygen saturation, is measured in percentage and is the amount of oxygen in the blood that combines with hemoglobin. It can be measured directly by pulse oximetry. With oxygen saturation, the normal range is 95 to 100%. HCO3, or bicarbonate ion, is an alkaline substance. A deficit of bicarbonate and other bases indicates metabolic acidosis. Alternatively, when there is an increase in bicarbonate, then metabolic alkalosis results. The normal serum bicarbonate level is 24 to 28 milliequivalents per liter. So let's recap to determine acid-base balance. You need to know and memorize these values to recognize what deviates from normal. The normal range for ABGs is used as a guide, and the diagnosis of many disorders is often based on blood pH levels. If the blood is basic, the bicarbonate level is considered because the kidneys regulate bicarbonate ion levels. If the blood is acidic, the amount of carbon dioxide in the arterial blood is assessed because the lungs regulate the majority of acid-base balance. The normal ABG values are the following. For pH, the normal range is 7.35 to 7.45. For PaCO2, the normal range is 35 to 45 mmHg, and it's considered a respiratory determinant. The PO2 range is 80 to 100 mmHg. The normal range for bicarbonate HCO3 is 24 to 28 milliequivalents per liter, and it is the metabolic determinant. Lastly, the normal oxygen saturation range is 95 to 100%. Please note that the bicarbonate range can differ from hospital to hospital and from one nursing reference text to another, so make sure that you follow what your school states is the normal bicarbonate range. Now, let's discuss the respiratory system, which regulates carbonic acid, a combination of carbon dioxide and water, by either eliminating or retaining carbon dioxide, CO2. CO2 is a potential acid when combined with water. An increase in CO2 or hydrogen ions stimulates the respiratory center. The medulla oblongata is the lowest part of the brainstem and controls respiration, being highly sensitive to changes in CO2. When you hyperventilate, you exhale carbon dioxide. With hypoventilation, you retain carbon dioxide. Anything that decreases respiration can cause respiratory acidosis due to chronic respiratory disease or central nervous system depression. The extra CO2 combines with water to form carbonic acid, inducing a state of acidosis, which is a common occurrence in emphysema. The kidneys activate their compensatory process, which occurs slowly, often over 24 hours or more, by increasing the excretion of metabolic acids through urination, thereby increasing blood bicarbonate levels. In respiratory acidosis, the pH is typically low, below 7.35, and the PaCO2 is elevated, above 45. The bicarbonate level, HCO3, is normal. So remember, the pH will be low and PaCO2 will be elevated. There are two forms of respiratory acidosis, acute and chronic. Acute respiratory acidosis occurs immediately, and if left untreated, symptoms will get progressively worse. This is a medical emergency and can be and become life-threatening. Chronic respiratory acidosis develops over time and doesn't typically cause symptoms. Instead, the body adapts to the increased acidity. For example, the kidneys produce more bicarbonate to help maintain balance. However, developing another illness may cause chronic respiratory acidosis to worsen and become acute respiratory acidosis. Respiratory acidosis is typically caused by an underlying disease or condition, also known as respiratory failure or ventilatory failure. The first risk factor is hypoventilation, which is a decrease in ventilation that increases the concentration of carbon dioxide in the blood and decreases the blood's pH, for example, with brain trauma, coma, and hypothyroidism. The second risk factor is chronic obstructive pulmonary disease, or COPD. In chronic respiratory acidosis, COPD patients' bodies try to compensate by retaining more bicarbonate to overcome acidosis. The third risk factor is respiratory conditions in which the lungs are unable to eliminate enough carbon dioxide produced by the body. The excess carbon dioxide causes the pH of the blood and other bodily fluids to decrease, making them too acidic. For example, pneumothorax, pneumonia, status asthmaticus, and aspiration. The fourth risk factor is drug intake, where an overdose of an opioid or opiates such as morphine, tramadol, heroin, fentanyl, or magnesium sulfate can cause respiratory acidosis. The signs and symptoms of respiratory acidosis are as follows. First, altered level of consciousness. Respiratory acidosis may be the result of an altered level of consciousness caused by encephalopathy, which is a general term for brain disease damage or malfunction which can be caused by anoxia, which is when the brain loses oxygen because of hypoxia or infections and drugs, or cerebral edema, which is when the brain swells, increases the pressure inside of the brain. The second sign and symptom is confusion, where acute respiratory acidosis may also cause symptoms involving the brain, including confusion, which is characterized by a decreased level of consciousness, stupor, drowsiness, and muscle jerks. The third sign and symptom is disorientation. Respiratory acidosis may result in disorientation, headache, or even focal neurologic symptoms. A fourth sign in the symptoms is when the lungs can't remove all of the carbon dioxide produced by the body through normal metabolism. The blood becomes acidified, leading to increasingly severe symptoms from sleepiness to coma. The fifth is tremors, which are manifested as shaking or jerking muscle movements. And the last sign of respiratory acidosis is asterixis, which is the inability to maintain the posture of a part of the body. A medical and nursing management of an arterial blood gas of respiratory acidosis includes the following: treating the underlying conditions. As a nurse, you will use medications like bronchodilator medications and corticosteroids that may be used to reverse some types of airway obstruction, for instance, those linked to asthma and COPD. Additionally, in treating underlying conditions such as obesity hypoventilation syndrome, which is often caused by significant weight gain, losing weight would reduce the abnormal compression of the lungs that leads to carbon dioxide retention. Another medical or nursing intervention would be providing medical ventilation or intubation through oxygen supplementation, because the additional oxygen will elevate the low oxygen levels in the blood. Remember to assess respiratory status and lung sounds. Managing hyperkalemia through the use of kayexalate, because acidosis causes potassium to move from cells to extracellular fluid or plasma in exchange for hydrogen ions. Kayexalate increases the amount of potassium excreted by binding potassium in the lumen of the gastrointestinal tract. In respiratory acidosis, nurses maintain adequate hydration by providing intravenous fluids and electrolytes as ordered. Patients may receive 2 to 3 liters of fluid per day, unless contraindicated, such as in patients with congestive heart failure. Nurses may also administer narcotic antagonists as indicated. An example would be Narcan, because those who have an opioid overdose will have hypoventilation, which will increase the amount of carbon dioxide retention. So if you reverse the overdose, you will correct the respiratory acidosis. The nurse will encourage the patient to splint after surgery and take deep breaths to facilitate air movements, which will prevent respiratory acidosis. Now let's recap. In respiratory acidosis, you will see an increase in the rate and depth of respirations, which will eliminate carbon dioxide and carbonic acid, thereby increasing the pH to a normal range. Let's move on to respiratory alkalosis, which can result from hyperventilation, as the lungs excrete too much carbonic acid, thereby increasing the pH. Caused by excessive CO2 excretion by the lungs, it increases the pH to greater than 7.45 and decreases the PaCO2 to less than 35. Bicarbonate levels will be normal during this period, so remember that the pH will be high and the PaCO2 will be low. Since respiratory alkalosis occurs quickly, the kidneys do not have time to compensate. Neurological symptoms such as confusion, paresthesias, and increased cell membrane excitability occur when the blood pH, cerebrospinal fluid, and intracerebral fluid levels increase acutely. The causes of hyperventilation include panic from panic attacks and anxiety, which are the most common cause of hyperventilation. Hyperthermia, where fever may manifest as hyperventilation. Brainstem damage causes central neurogenic hyperventilation. Metabolic acidosis, which causes hyperventilation, most often as a response to hypoxia, metabolic acidosis, increased metabolic demands, pain, or anxiety. Diabetic ketoacidosis, the only known compensatory response to metabolic acidosis, is characterized by hyperventilation, which leads to consecutive respiratory alkalosis. Pregnancy, because progesterone levels are increased during pregnancy, where progesterone causes stimulation of the respiratory center, which can lead to respiratory alkalosis. And salicylate toxicity, which causes respiratory alkalosis, and by an independent mechanism, metabolic acidosis. Now, hyperventilation is a sign that respiratory alkalosis is most likely to occur. However, low carbon dioxide levels in the blood also have several physical effects, including numbness due to increased neuromuscular irritability, which can cause a person to lose feeling in a particular part of the body. Nausea, confusion or change in mental status. A tingling sensation, which is a prickling sensation that is usually felt in the hands, arms, legs, or feet, but can also occur in other parts of the body. Tachycardia or palpitations are the perceived abnormality of the heartbeat characterized by awareness of cardiac muscle contractions in the chest. Tetany, also known as tetanic seizure, is a medical sign characterized by involuntary muscle contractions. Convulsions are a medical condition characterized by the rapid and repeated contraction and relaxation of the body's muscles, resulting in uncontrolled body movements. Therefore, it is essential to initiate seizure precautions, And last, signs and symptoms of hypokalemia and hypocalcemia, which is due to persistent respiratory alkalosis that induces secondary hypocalcemia and hypokalemia, which may cause cardiac arrhythmias, conduction abnormalities, and various somatic symptoms such as paresthesia, hyperreflexia, convulsive disorders, muscle spasm, muscle twitching, a positive Chvostek's sign, and tetany. How do we manage respiratory alkalosis? The treatment for respiratory alkalosis depends on the underlying cause. Treating the condition involves reducing carbon dioxide levels in the blood. The following strategies and tips are helpful for respiratory alkalosis caused by overbreathing due to panic and anxiety. We can have our patients breathe into a paper bag because breathing through it fills the bag with carbon dioxide, helping them inhale the exhaled air back into their lungs. Therefore, we need to teach the patient to breathe more slowly. We're going to treat underlying conditions with medications, for instance, administering an opioid pain reliever or anti-anxiety medicine to reduce hyperventilation. We're going to teach relaxation techniques such as breathing exercises to help you relax and breathe from the diaphragm and abdomen rather than the chest wall. Other interventions include reducing environmental stimuli and speaking calmly in a quiet voice. If the hyperventilation is due to safety reasons, we want to stay with the patient. We may have to lavage the patient, especially after massive aspirin ingestions, so the gastric lavage, which is an aggressive goat gut decontamination, would be advisable. We would correct the hypokalemia and hypocalcemia, and lastly, we would provide oxygen to our patients as needed because oxygen therapy helps prevent hyperventilation. Here's a recap of respiratory alkalosis. An alkalosis patient needs to decrease their rate and depth of respirations, which will cause carbon dioxide retention. Carbon dioxide will then combine with water, resulting in increased carbonic acid levels, which will help return the pH to normal. Before we move on to metabolic acidosis and alkalosis, let's take a look at the renal system and see its importance in acid-base balance. The renal system is the body's long-term regulator of acid-base balance. The kidneys eliminate non-volatile acids, such as lactic acid, which is produced during cellular destruction, and hydrochloric acid, which is secreted by the stomach. The renal system regulates bicarbonate and extracellular fluid, but it takes several hours to days to become effective. However, when the renal system begins to function, it selectively excretes or retains hydrogen ions to maintain the body's pH balance. That's a wrap on part 1. Thanks for joining me on this journey. Be sure to come back for our deep dive into metabolic acidosis, alkalosis, and ABG analysis. If you've enjoyed this content, I'd love to hear your thoughts. Please leave a comment, give it a thumbs up, and hit that subscribe button. Exciting things are coming, including an ABG interpretation video that you won't want to miss. Let's keep the learning going together. Happy studying from NurseEdScholar.